Good afternoon, everyone. Welcome to joining us. Should I say good morning, depending on what time you're, what region you're joining us from. Welcome to this webinar, all about long-term conditions, with particular focus on high-performing healthcare systems and multidisciplinary teams. My name is Richard Taunt.
I'm Annette.
And it's fantastic to be joined by John and Laurie from CCA Massachusetts, 8 a.m. in beautiful Boston. John, Laurie, welcome.
Thank you.
Thank you.
Lovely. We were just talking Christmas trees already up. Did you have a good Thanksgiving?
It was lovely. Thank you for asking.
Yes, thank you.
Excellent. We are certainly in the Kaleidoscope offices very jealous of our American colleagues who get just have a bonus Christmas dinner.
Yeah, it sounds amazing.
2 days, usually 2 days
That's
off
right.
too. So it's Thursday and Friday, so it's a good holiday.
It's a nice time. And John Lloyd, we're going to be hearing more about CCA as we go through. Just to say, if you're wondering what on earth it is you've joined, this is a webinar series, an event series. It's particularly exploring long-term conditions, and we'll explain more about what we're doing and why in just a moment. But just to say this, over the next 55 minutes or so, you're going to be talked out a bit. There's going to be some presentations, but crucially, we'd love for you to get involved. 3 ways you can do that today. You can use that Ask Question feature on GoToWebinar. You can email us if the question thing isn't working, hello@kaleidoscope.healthcare, or you can tweet using the hashtag #SusHealthUK or the Twitter handle KScopeHealth. If your computer decides to have a midlife crisis halfway through, don't worry at all. We are recording today's session, and so you can watch it back, as well as sharing it with all of your family and friends after today, so that others can hear our discussions. If you are joining on Watch Again, very welcome to you. That that Ask Question feature may not work, but of course we still welcome any observations, comments through email or Twitter. So please do send in comments, and we'll come to a discussion from about halfway through. It's worth saying that this event series partnership between Kaleidoscope Social Enterprise brings people together to improve health and care. One of the ways we do that is try and think of and encourage the conversations which need to happen but often don't, particularly think about where those operate across different boundaries like a huge ocean. Annette, AbbVie.
Yes, thank you. For those of you who don't know, AbbVie is a global pharmaceutical company, and we work to develop innovative medicines for areas where we perceive an unmet need. Now, we're really proud of the medicines that we develop, but we do recognise that we are only a small part of a huge health and care system that's working to get the best outcomes for patients. So that's why, through our Sustainable Healthcare Initiative, we work with individuals, organisations, networks, partnerships to find new and innovative ways to deliver the outcomes that patients want and need, working with them to help people feel empowered to take ownership of their healthcare and really make the best decisions about their own treatment and care. This series of events is just a fantastic way for us to hear from people like yourselves joining today who are working in the system, and wonderful people like John and Rory who have joined us all the way from America to find new ways that we can be delivering the best outcomes to patients and discuss how we can do more of it all the way across the globe.
Lovely, and thank you. And we're talking just before we started that this is the third in a series of 3 webinars.
The final one.
If you've been with us for all 3, award yourself a gold star. Thank you very much indeed. Previous webinars available to catch up on the Kaleidoscope YouTube channel. Please feel free to do that. But after today's discussion, don't rush away quite yet. So I'll talk a bit about the whole theme of this series before we go into hearing more from John and Laurie. But we've sort of termed this change in a cold climate. Why have we done that? Because we wanted to explore how you can make change in an environment, in a climate which often feels inhospitable. So what can we think and learn from practical examples of where change has happened, and try and get into some of that nitty gritty of actually how change actually happens. John, Laurie, does nitty gritty translate? Is that in particularly English? Just to check, I always wondered. So it's actually getting into some of the detail about, we know that change is needed, but how actually can this come about? Why this particular focus on change? A quote we often reference from a US economist, Paul Krugman, talking about the economy, where he says that productivity isn't everything, but in the long run, it is almost everything. We like to think that in healthcare, you can just cross out productivity and put in improvement. Actually, we can't go on just pumping money into a healthcare system which isn't able to improve how it improves, which is why we want to get into that in this series. And so in terms of getting very meta now, what needs to change about change? Striking finding we should possibly talk more about than we do is that from the NHS staff survey of hundreds of thousands of NHS staff, only 55%, only just over half, felt they were able to make improvements happen in their area of work. So imagine if that was 90%. Imagine if we had a NHS workforce which felt better able to make those changes. What would that look like in terms of the outcomes we're able to deliver for our populations? So we talked about long-term conditions, particular focus in. We talk about long-term conditions, chronic conditions, a great deal. And you've heard statistics such as there are 15 million people in England, at least one long-term condition. This is a big issue. It takes up a lot of our healthcare capacity, over half of our primary care GP appointments for those with long-term conditions, and a lot of financial impact as well. About 70% of that primary care budget spent on those with long-term conditions. It'd be interesting to get into some of these comparatives, John Lawyer, when we talk in just a moment. But actually, there's a whole range of things that possibly we should talk a bit more about. Firstly, that there's no single country which can look across their whole system and say we have cracked long-term conditions care. This comes from an international survey run by the Commonwealth Fund, which was looking at patients across a range of different countries. One of the questions being, did you discuss or did you not discuss with a health professional your treatment options, including side effects? So this is did not discuss, so low is good, high is bad. And you can see a real variety, and even the Scandinavian countries, which would normally point to say, oh yeah, they're streets ahead.
Right.
Actually, on this footing, not particularly. So Norway there is that 52% column. 52% of adults with chronic condition didn't discuss treatment options, including side effects, with health professionals. So this is something which we're all struggling with. Stat number 2, we know that multimorbidity, people with more than one long-term condition, has a real inequalities element. So those with multimorbidity, it appears 10 to 15 years earlier with people living in the most deprived areas compared to the most affluent. And finally, the last stat, which I'm very pleased to be saying for the last time, at least this year, is that it's still 46 years and counting since the 1972 government white paper, which proclaimed there is a need for far more services that support people outside hospital, and often what there is could achieve more if it were better coordinated with other services in and out of hospital. 1972. You can pretty much cut and paste, and I'm sure something similar to this will be in the NHS long-term plan coming out shortly. So something needs to change. We've talked about this a lot. What can we do differently? So how can we find insight about how we meet our long-term conditions challenges from other contexts? And in particular, focus for today, how can we learn? What can we learn from those high-performing healthcare systems which have particularly thoughtfully about this and really tried out some interesting changes around patient-centered care, which is probably, John and Lloyd, the longest preamble you've ever had to, and now our speakers. But just a footnote before we go on, which is in putting together this event series, we had a conversation with the Commonwealth Fund, which is a leading US-based think tank, and we said to them, so if you're going to tell us just a couple of places which we should look at in the US, who are doing really interesting things about chronic conditions care, literally the first bullet point in their email back was Commonwealth Care Alliance in Massachusetts. So no pressure, John and Laurie, no pressure, but you're coming very highly recommended. I'm very much looking forward to what you have to say. Laurie, I'll pass over to you. Thanks again so much for joining us this morning.
Thank you so much for having us. It is, it's really an honor to be here, and what you read from the 1972 white paper, I just wanted to, it's been the story of my whole career, which fortunately has not been since 1972, but really thinking about how do we take really good care of people in a place, in a location that they want to be taken care of. Nobody wants to be in the hospital. Having just spent several days with a family member in the hospital, nobody wants to be there. And so what can we do to really make a difference for people? And also the statistic that you guys noted about the fact that more people with chronic conditions live in deprived areas. That's really what we're all about at Commonwealth Care Alliance. And we really look forward to talking with you guys about patient-centered care, care in the right place at the right time by the right person. Why don't we take a minute and just introduce ourselves briefly? John?
So I'm John Lockton. I've been at CCA for now over 9 years. I'm currently Chief of Innovation.
And I'm Lori Tischler. I'm the Senior Vice President of Medical Affairs. John and I are both physicians by training, primary care doctors. I came to CCA almost 2 years ago, and the reason I came here was after working in an academic medical center for my entire career, I found that what I wanted for my next phase was to really think about how do we take really good care of vulnerable populations, and how do we improve from the inside, how can we improve the health system? And I really, as I sort of investigated my options, felt that CCA was doing all of those things. And it's been a pleasure and an honor to be part of this team.
And I think I came here 9 years ago for exactly the same reasons. So I think that the legacy of CCA since 2004 has been finding providers and physician leaders and nurse practitioner leaders and social work leaders who see a different vision of healthcare in the United States and really want to impact populations that in general have not had the level of engagement that we would all hope for.
So starting with our first slide, which is, I guess, number 20, we are based in Massachusetts on the East Coast of the United States. We're not-for-profit and community-based healthcare organization dedicated to improving care for people that in the United States we call dually eligible. That means that people have Medicare, which is a federal program, and Medicaid, which is a state-based program. Medicaid is income-based for people who live in Massachusetts, which means that all of our patients across the board have low income, often very low to no income. And Medicare is an entitlement program for people over 65, meaning that anyone in the United States, with a few very limited exceptions, is eligible for Medicare if they're over the age of 65. People under the age of 65 who have Medicare are disabled. And they may be disabled from medical conditions. They may be profoundly physically disabled, intellectually disabled. Importantly, they may also have severe psychiatric disabilities. So a large portion of our members under 65 have severe persistent mental illness. And I think that's very important to kind of think about when we think about our model. And as we've both said, you know, the mission is to really make a difference for these patients, for these members. And we try to do this by first providing care. So one of the things that is really important to know, actually, let me back up because I always forget this. We are financed by the state and by the federal government. So for every member that we have, each patient gets a certain amount of money from the state, from the Medicare funds, and then a certain amount of money from the federal government, from the I got it mixed up, from the Medicaid funds from the state, Medicare funds from the feds. And that is our operating budget. So from that budget, we pay for everything. So if you need to have a visit with your physician, you know, it comes out of those funds. If you are very, very sick in an intensive care unit, it comes out of those funds. But also what we're able to do, because we have that, forgive me, chunk of money, we are able to think about how we want to spend that money, which means that in addition to the traditional healthcare we are able to provide a substantial amount of care management, what we call long-term services and supports, which are the people that help our patients. So that might be a visiting nurse, it might be a homemaker, someone who can go into someone's home and help them to cook or clean. It might be what we call a home health aide, someone who's doing more personal care. And then it's also durable medical equipment. But as you can see on the bottom, the bottom bullet there, that we're nationally recognized for an innovative model of care. And it is having the kind of global capitation that really allows us to innovate in some fascinating ways. So what I want to do is tell you a little bit about our model and then have John also share with us some of those innovations, because it's all exciting, but the innovations are the things that make people say, wow, that's a really neat idea. Why didn't we do that? Could we do that? So each of our members, when they join CCA, and they do that by two ways, most of our seniors elect to become a member with us, and our under 65s who tend to be, as I mentioned, they have more behavioral health disease, they tend to have more chaotic lives, they're more likely to be homeless, that sort of thing, are often assigned to us by the state. Patients have the opportunity to opt out, but it's our job to find them and engage them. Every single one of our members has a person, which means that when you become a CCA member, you are assigned a care partner, we call them, and those vary, right? That might be a nurse practitioner or a physician assistant for patients who have highly complex medical needs, who maybe are not in close touch with their primary care physician, or for people who can't get out of their house. And that nurse practitioner will go to their home and help provide care and help to make connections between the patient and the rest of the healthcare system. Some of our members maybe have low income and some chronic problems, but they may be very solidly linked within their community and have a strong family support. And then they need fewer services. And somebody like that might have a phone-based nurse or social worker, or what we call health outreach workers, which are community health workers. Some of our members have primarily social issues. They're at risk of becoming homeless. They're at risk of going to jail or going back to jail, or they don't speak the language but are incredibly educated in their home country. For some of those people, simply having a community health outreach worker who is able to translate the system, whether it's translating in language or in sort of form, and those are the people that are connected to each of our members. And I think in many ways, the fact that we are able to cross space, meaning go into a member's house when it's appropriate. Sometimes, as I mentioned, our members don't have homes. So you will see some of our health outreach workers and nurses meeting someone in a park, meeting someone at a coffee shop, any number of things, so that we try to meet people where they are.
And I think I'll add just that very good description is the basis of what we do is an individualized care plan. So a patient comes into our system and we go out and say, what are your needs? And in a traditional medical system, that is just focused on, you have hypertension, this is what we'll do, or you have hyperlipidemia. But we go out and talk about, well, what's your housing situation? Do you need to be supported through long-term service supports? Do you need durable medical equipment? Do you need other components of what health is in a holistic fashion? But that is really structured by this engagement of you as an individual, us as a provider of holistic healthcare, and how we work together to provide the best plan for you.
When I went to see one of my first patients at CCA, I was making a home visit, and I had reviewed all of her medical problems, and she had probably 6 chronic issues. I had ideas. I was going to fix her diabetes and her blood pressure. I was going to decrease the amount of opioids that she took. And her care partner looked at me and smiled in that way of, you're really new, aren't you? And said, first of all, we're going to make sure she doesn't get evicted. Secondly, we're going to get her some home delivered meals so that she isn't ordering fast food takeout every day. She had gained, I think, 80 pounds in a year, or shall I say 4 stone. She looked at me and she said, after we do that, and after we make sure that she doesn't get evicted or she can move into a place where she can keep her cat, she said, then you can dicker with her blood pressure. And I think the point is that we approach people as people. We approach the social determinants of health, which I think, we all know make up so much more of what we can make a difference in for people. And then we tackle the medical issues. So I want to turn to John for a minute so he can tell you a little bit about some of our innovations.
Sure. And I think, can we move to the next slide? Great. So I think what you do on this slide here is basically we want to talk about OneCare and senior care options and then move to the innovation component. But this is just an outline of the folks we take care of. I'll quickly just kind of give a brief history, which I think is important. The CCA started primarily in 2004 taking care of what we call senior care options, which is the over 65 dual eligible population. As Lori mentioned, that population in general has aged into the Medicare program in the United States and also has the challenges of social determinants that brings them into a Medicaid structure. So CCA was originally designed to care for that population, which was very successful, but we all knew that ultimately the larger population that really was challenged by a lot of the access to care issues and the ability to impact holistic health was under 65 populations that had disability, either physical or behavioral health. And that's the OneCare population. So as you can see from the slide where we are is that you can see these demographics, and I won't go into all of them, but these are very complicated patients. These are in the United States probably about the 2% of the highest utilizers. I don't love that term, but these are the folks who really have, in my mind, the greatest need for a holistic approach to healthcare and truly also have the most ability to impact their overall health structure. So CCA has evolved and has learned, but as we go along, the 3 tenets that I think have always been primarily structured is one, is these are folks who need care, and the care is defined by them and delivered by us, and that's a conversation that's always ongoing. So as folks go through and join our program, what they need now is not what they're going to need in 5 years or 10 years. And in general, in a medical model, in that when I saw patients before CCA, 1 year they kind of need this, 5 years they may more need intensity of this, but
that's right.
It doesn't substantially change. Their social determinants, they're stable, their medical issues may get worse and their health may get worse, but the environment surrounding them is relatively stable. At CCA, 1 year does not mean 2 or 3 or 4. So there's always this need to understand where our patients are. And every conversation I think we all have here is, where are you at and how can we help it? Not the old conversations of your blood pressure is 182 over 70. And again, and we're good at that, but that's not how we impact these populations. So the 2 things I do want to call out here is on the OneCare program, you see 64.2% of patients have significant serious behavioral health issues. And that's really important because we know that people with behavioral health have probability of dying 2 times at any age than those who don't have behavioral health problems. So this is also a human issue.
Right. And the homeless population, which is hard to measure, obviously, for obvious reasons, but we know that about 7% of our members are homeless at any given time. And then there's probably another significant percentage who are marginally housed. And that people, again, who are homeless, they die of the same things that we all die of. I think there's a tendency to think, oh, people who are homeless die of exposure. And thank God a very few number of them do. They die of heart disease. Yeah. They die of cancer. They die of pulmonary disease. And they die 20 to 30 years before people who are in more stable living situations do. And it's a challenging population. This is also a population who has not had an easy time with the healthcare system and who are not, they're not your sweet little old lady who shows up at the door with cookies when the nurse comes, and sort of making relationships with members like this is really challenging, and our staff is just, I am in awe of them every time for their patience, their patient-centeredness, their willingness to have a door slammed on them and go back tomorrow.
And I think so. We'll move to the next slide if that's okay. So the care model is based on a longitudinal relationship with patients. These are not folks who generally on the first visit that you've bonded with and that you're going to make substantial changes. So everything we do is structured around this idea of meeting the patient's need, but longitudinally understanding it's maybe the 15th visit or the 30th visit where we can really make a difference. So we have primary care clinics, which are primarily focused on behavioral and physical disability. I don't want to, one of the things going around now is we started that primary care clinic back in 1990. It's hard to tell exactly when we started, but we probably have now patients with spinal cord injury
Yes.
who are living longer than anybody else in the United States because we really based the first programs on how to do home-based care for patients with spinal cord injuries. But that primary care clinic is set up to care for patients primarily in their homes, but for those who just can't access the system. We also have community behavioral health CSUs, which are structured to provide behavioral health for those patients in the United States who don't need what we call locked behavioral health unit, but aren't going to do well just out in the community, and they end up in our ERs for 48 hours or 72 hours
Right.
without any meaningful intervention, and then they're back in a month. So these crisis stabilization units are housing at the same time that we provide intensive behavioral health to help them move to a different level of both behavioral health stability and at the same time work on their medical issues.
Right. And the CSUs we have a floor of a hospital. It's not part of the hospital. We rented the floor. And then we also, we purchased a house. It's a triple-decker house in a neighborhood of Boston so that people are really in a kind of milieu that feels safe to them. For some people, that's a home-based setting. For other people, it's a more institutional-based setting. But one of the things that the CSU is able to do is to really develop a plan for patients so that they're not just there until they're not suicidal, for example, but they're there, and then sometimes, all too often, I think people leave psychiatric facilities with a piece of paper saying, call this day program or follow up with an outpatient therapist. And what we're able to do is, in rare cases, we are that therapist, or we provide that bridge care until they get a therapist or a medicating professional. But we're able to have them go from one place to another so that it's much more seamless. And yes, of course, people come back to the CSUs because psychiatric illness is chronic, but it is a much better system in terms of keeping a sort of tight network around people.
It's coordinated, and I think what we'll do is, I'll quickly speak to this, and we'll kind of talk about how it is coordinated. So we also have what we call RAP model, which is we have primary care, our own primary care clinic, but most of our patients are a primary care provider out in the community. And both Lori and I have been those primary care providers. This is a nurse practitioner or an RN who can see patients in their home and augment the care we want to give. So we know that a provider in the United States is in a clinic, can't impact these patients. But if you have a skilled partner in that, and that's what a RAP partner is, who can go out and help you with the care that you would like to provide in their home if you had the ability to do so. We also understand hospitals are a key component to the care model. Most of my career has actually been spent in a hospitalist role. And so we have access and ability to see patients in the hospital, primarily at Boston Medical Center, our primary tertiary care hospital, to alter and adjust the care. And then finally, we have mobile integrated health. It came out a little bit, which are these community paramedics that we've repurposed to be in-home providers. So these are folks who can go out, evaluate under medical control, and who can do things like laboratories, give IV antibiotics, give IV diuretics, and to bring acute care to their home. Any one patient, and I'll give a kind of an example of a patient I recently took care of in the hospital, is basically they're at Boston Medical Center. I, as part of CCA, sees them at their home. Then I call their primary care provider who comes into the hospital to see them with me to kind of develop a plan. Part of that plan is that they're going to go to the CSU because they have a behavioral health issue that needs to be stabilized. that is not a medical issue, but we know unless we stabilize the behavioral health issue. So it's an immediate discharge to the CSU from Boston Medical Center that we handle.
Right.
At the same time, if that patient has a decompensation at the crisis stabilization unit, let's say they have heart failure as well as schizophrenia, the mobile integrated health team can go there and give them diuretics there, or if they were at their home, to avoid them needing an ER. And we do these things, I think, as Lori mentioned, because we have the capitated dollars. We have risk-adjusted, capitated Medicare and Medicaid dollars. That is a pool of money that we can determine what the right intervention is. And I think that's another key component to understand, that those dollars allow us to flow into what we need to do. And that need to do is the flexibility to create an individualized care plan.
All right.
I guess we should move to the next slide. So again, this is just going over some of our results on the HMO. We can move, I know we're running short a little bit of time, so we can move to the next slide. And this is the OneCare.
The key things about these two slides, which you can go back and look at if you want, is that this works, that it saves money, that there's enormous patient satisfaction for this. For the OneCare plan, we're we're tied for the top rated plan in the country 2 years in a row. And this is not a population that is easily satisfied with what they're getting from the healthcare system. So that's something that we're particularly proud of. Another number with the mobile integrated health, about 84% of the patients that we see at home don't go to the hospital. And the other 16% do go to the hospital and get admitted, which suggests that we are identifying the people that need to be in the hospital. And believe me, this is not a hospital diversion program. We want the people who need to be in hospital to be in the hospital. But people who don't need to be in the hospital, many of our members, if they come into an emergency room, people take one look at their problem list or their medication list and think, oh my goodness, this patient is so complicated, they need to come in, when they may be at their baseline. So being able to do that has, patients love it. Patients love their paramedics. We'll hear a patient say, can you send Dan out to see me? But they also really, it's helpful when the paramedic is scared or the physician on the other end of the line is scared and says, whoa, this person should not be at home. We not only get them to the hospital, but on good nights, the paramedic can follow them there and give report to the hospital team so that it's clear what the patient's baseline is and what they need, which often, not always, but often helps us direct the services and support that they need.
And I want to just call attention to the results here just to make 2 points. One is these are incremental changes. Part of my other role here is I do our venture accelerator, where I see lots of interventions telling me they're going to reduce emissions by 80% or 90%.
Right, exactly.
That's not true. So when we see these real numbers, those are real. I think that's when you think about incremental change. That's real. And what you often hear in my other role is like, no one's going to impact 80%. It's just picking and choosing. And the other aspect of this, though, is given the cost of these patients, a 3.3% or 2% is real dollars too. We roughly take care of now 30,000 patients. That it is over $1 billion worth of premium. So if you make changes, that's not inconsequential to how we're providing more efficient care while we're also improving the quality. And again, the other aspect is the top-rated plan is not by regulators, it's by patients.
That's right.
So that's a key component. So to have patients say, we think you're the top-rated plan that provides these services, and at the same time show some reductions in how ED utilization, 30-day readmissions are happening, I think is an alignment that's important. But just for the general audience, I really would doing this a number of years, 2 to 3% is okay. Now, if you can 2 to 3% every year, that really adds up. But it's a crucial component to understanding that the buy-in for everybody has to show not huge gains, but you're moving in the right direction. And you're moving in the right direction that's aligned both with your goals as an organization, right? Great quality care that's cost efficient, that patients really see the value for.
Exactly.
So we'll go to the next slide. So I think we put this in because long-term supports, this is about health is a human construct. It's not a medical construct. And I always try to remind that myself. It's so easy, especially in the hospital or even in an office, to see people not as people but as patients.
Mm-hmm.
And I think one of the other key models is when you go to their homes, you see them as people.
Yes.
And I think that's a component. So whenever we go, and I think that was when I came from a relatively more socially determined stable population in a town south of this, I would do some home visits, but it was still the patient mode. The first thing I had to do to change my lens is to see these as people who had lives that impacted everything else I tried to do, and that the pyramid was 90% of their life and then 10% of their medical issues. And so I think the slide here is always to remember for us, and I think we do this well, but everybody we go into, it's one person helping another person, and we have tools and knowledge. They have tools and knowledge, and then we come to an understanding of where that meets.
And that's something that within CCA we call the dignity of risk.
Yeah.
It's not just the dignity of risk, but in part it's the respect that our patients are people who know how to make decisions, and that sometimes they make a decision that we as healthcare providers, or maybe just as humans, don't agree with. And how do we work together? I mean, I think that many of us have seen healthcare providers say, well, if you're not going to do what I want you to do, I can't help you. And we don't do that. We say, okay. You know, my greatest example of this was a man who I believed was having a heart attack who would not go to the hospital. And I was like, okay, what are we going to do tonight in your house to keep you as safe as I can possibly keep you when I really would like you to be like under glaring lights and getting a catheterization and all of the things that I believe you need. And we spent an hour and we talked, and he was, not making the decision I would make, but he was making a reasoned decision for himself. And so I made as reasoned decisions as I could medically. We treated him as much as we could at home. And the next morning, when he was actually able to talk with his care partner, who he has a strong relationship with, he was willing to go to the hospital. But that's the kind of relationships that we develop with people. And the long-term services and support are a reminder that things like food, you can say food as medicine or an apple a day keeps the doctor away, but we published a study in Health Affairs that showed that giving people home-delivered meals of any kind actually decreased their emergency room use, their hospitalization use, and specifically medically tailored meals for their specific medical issues did that even more. So it's things like that. It's programs to help people so that they're not lonely. Or like the patient I saw who, she was actually more concerned about the fact that her cat might not have food than that she didn't have food. So really trying to understand what is that drives people and meeting them as much as we can.
So I know we want to go to discussion, and I'll just when people ask me what CCA is about, I give them three things. One is it's human care that leads to medical care. That's so important. Two, it's these individualized care plans that only can be developed with longitudinal caring relationships that builds trust. And third, on the financial side, it's risk-adjusted capitated dollars that give the flexibility for providers like Lori and myself and everybody else at CCA to think about how to get the right care that is not encumbered by traditional medical thought. So those when I often think, I don't know if you have any.
I think that's exactly right.
And that's sort of it in a nutshell.
Right, John, Lloyd, thank you so much. You've kindly given us your key contact details.
Yes.
Which now you'll get 7,000 emails from people at the NHS going, quick.
These are fun kind of emails for us.
Yes,
so
trust us.
If people have questions or want to hear more about any of our programs, we are more than happy.
And the last thing I really will say is Lori and I still practice in the environment we create, which is really important. So I think that's a real element.
Yes.
We make sure we see patients because there's nothing more illustrative than actually seeing someone and seeing how the system interacts at the pure level of a provider seeing a person.
I think that's right. And as John was talking, there were sort of visions of people's homes dancing in my head. And if you don't work in a low-income area, you may have your image of what it looks like to live in subsidized housing. And what I will tell you is that for most of these patients, their houses look like your house. They have pictures of their families. They have things around them that matter. I think they're clean. They're doing their very best to make their life what they are able to make it, and that is consistently eye-opening and humbling for me.
Thank you,
John. Thank you so much. One of the limitations of the webinar format is that it doesn't allow the audience to show their appreciation, but I think we still can. So, thank you. John, thank you so much. I often think sort of the mark of a good presentation is just how quickly you've been feverishly scribbling notes. There's a whole range of things, John Laurie, which I now just want to go away and get tattooed on my arm. Care defined by them and delivered by us. That this is health is a human concept, not a medical concept. I'm sure we've had a lot of people on the line who've been nodding away. And we'll have questions and observations. Thank you so much for your run through, and that'll come to you in 1 second. But just to say, if you're wanting to join the discussion about quarter analysis, you can use that Ask Question feature. You can email us, hello@kaleidoscope.healthcare, or do feel free to tweet. The hashtag is #SusHealthUK, or Kscope Health is the Twitter handle. Any one of those three is fine. Annette, reflections, questions?
Yeah, I'm just in awe of the work that you're doing, really. It's incredible. I think we have so many initiatives in the NHS right now, which is trying to achieve what you're doing. We've got social prescribing, personal health budgets, shared decision making, personalised care plans, but they're all happening in silos of each other and aren't quite hitting the mark yet. And I think you really summed it up in that dignity of risk and feeling comfortable as medical professionals to really put faith in the patient and truly listen to their needs and what they want. That really hit home for me. And also the capitated dollars and having that freedom and autonomy to spend your money. I don't think our systems are quite set up for that yet. But I wish they were. This is incredible. I guess. Did you want me to ask a question, or should we go straight? I'm conscious lots of people.
There'll be questions. You can still chair prerogative for one moment.
I guess from my perspective, I'd love to hear from you what really helped you shift and put your faith in the patient and the person, and put their needs above and beyond what was sometimes your immediate medical instincts, because I think that's really hit the crux of the conversation for me today.
I think that goes back to kind of our founding. So was it 1980?
Yeah, 1980.
There was a practice which was called Urban Medical Group, Boston Community Medical Group, and it was a small practice that was founded by our founder, Bob Master, and he and Marie Felton really were struck by the needs, and this was kind of within the disability movement. They were really struck by the needs of the disability community and listening to what that community wanted, and having them say, we may be profoundly physically disabled, but we know what we want from our life, and what we need is for you to help us achieve that. And so founded on that kind of small practice really became the philosophy for the whole organization as we grew, first with the Senior Care Options program in the early 2000s, and then with the OneCare program which began in 2015.
And I'd echo that. I think, there's a phrase that our disability community uses, nothing about us without us. And I think that's true of everybody. So I think that's true of every patient, not just those we serve. But I think so often, I'm reminded whenever I do engage in the kind of traditional healthcare system, it really is about the system and not the patients. And I think that mantra that our founder, Bob Master, who I literally first heard back in 1993 when I was a medical student at our state university, I heard that, and it really, a light clicked off that what I heard Bob talk about was so different than what I was experienced as a medical student. And I think CCA is the manifestation of that view of that a true partnership is going to make a difference in people's lives has to be weighted equally.
And then I think the other piece that weights equally that we haven't talked about as much is within our own sort of organizational culture. There is not a lot of hierarchy between different licensures of providers. There's an acceptance that people who have medical degrees may think about things in a different way. But equally, I understand that somebody who's an RN has a very different approach and way of caring for somebody. And I think the respect that we are able to have for one another in the work that we do together also helps us translate that to our members and colleagues.
So I'm going to jump in on the back of that, if I may, and just say please do send through questions, comments, observations. We'd love to know what particularly struck you whilst listening to John and Laurie. So I'm going to go really specific, if that's okay.
Yes.
I've got this out, which is when you're recruiting people, how do you select the right people to work for your model? Because I was really struck by your point about the population group you work with. Then they're not giving you cookies, and they're more likely to object than welcome, perhaps. So there's a whole skill set there, I imagine, which is needed to both work with your membership, with the individuals you work with, but also to work in that team. Whereas you may get some people in other organisations who would actually want it to be all about them rather than their team, and actually struggle possibly to build those constructive relationships with that set of individuals you work with. So very specifically, how do you recruit? But then how do you make sure that you do have the right staff and develop them to be able to work within your model?
I mean, it's something we talk about a lot. We talk about what is our secret sauce and how do we get people. Partly, people who learn about what we do and are intrigued by it are often the people who come to us. So getting people like me and John and our chief of care management, Laura Black, to be out there talking to people. I think, I try to have as many medical students, nursing students come and learn from us and follow us. Those are things that we do. In the end, it really is about the person who's applying for this job. And we are very honest about what it's like to work here, about what the wonderful things are, and it's mostly wonderful, and about what people's challenges are. And if they are not, and it's often kind of self-selected. But one of the things that we have these town hall meetings with our CEO, and one of the things that one of the human resources people were saying is that our best source for getting new employees is our current employees.
I think modeling these behaviors is so important, both the clinical and other. So I know whenever we're working out on floors or in offices, people say, I like what you do. Mm-hmm. I like how you think about this. I want to practice differently. So I think that's crucial. I'll share when I first got hired here, the two things that I was told I had to have were be non-judgmental.
Right.
And that's really hard because that's what we're trying to do as providers, and to have a lot of perseverance. So that's the first. My interview here, and I think it's the same thing as it was when I interviewed here. Is those were the two things I was asked whether I could commit to. And I think that is Laurie had talked about earlier, the dignity of risk. That's what that's about. Ultimately, is being non-judgmental, riding along with the journey, and being persevered. Not to say, okay, I give up because it's hard. When it gets hard is when you actually have to be even more engaged. And I think this works for some providers. And I want to highlight that, we also understood from the very beginning that, a provider in the office may not be able to do that. They may want to. That's why we need to augment what they do.
Right.
And every time that we have an opportunity to touch a provider and augment them and say, hey, listen, again, we were those people. I want to do the right thing, but I can't. Help me do the right thing. And every time you help a provider do the right thing, that's putting a little bit of DNA. So when they see their next patient, they may think a little differently about it too.
Right. And I think, sometimes providers who are in more traditional settings don't understand what we do. And I was translating an incident between one of our care partners and a cardiologist in his office to explain what we were able to do for the patient. And the physician was very quiet on the other end of the line. And then after a minute said, okay, thank you for caring so much about my patient. And that it's not that we want to remove their patient, it's that we want to augment. And being able to explain that to people. I've given talks to physicians and had people come up and say, this is what I went to medical school for. And so it's not for everybody. And I think you have to be able to bury your ego.
Yeah.
You have to, it's not about you. And that's hard for all of us at any time.
Yeah.
I don't know about the sort of physicians working on your side of the pond, John Lloyd, but all of our doctors, they swallow their ego all the time. You don't have that issue. It's probably just a US thing.
I think so.
And that phrase about this is why I went to med school, I think that really resonates. I think you do see that a lot here. With particularly sort of our medical colleagues, but I think a whole range of people working across healthcare wanting to be involved in the sort of conversations and discussions that you've been involved in here.
So I think you can replace, I went to medical school, I went to nursing school, I went to social work, I went to whatever. I think the answer to it is you went to do that because ultimately you wanted to make people better, however better is defined.
And we try to enable our employees to come up with really great ideas. I mean, John is the chief innovation officer, but he's not the only person who innovates. We recently had a health outreach worker who are at a level of clinical skill. They don't have clinical training. They have sort of human training and training in their school of life. But what they actually did was 3 or 4 of them put together an open house for members who were having trouble with housing.
Yeah.
And, they got a room and they told the members when they could come, and they helped people fill out applications, and they gave them tips about how to approach different kinds of public housing or private housing. It was a huge success. Our doctors decided that they wanted to try to help some of our newer members understand, actually it wasn't just physicians, it was a team of people at one of our clinics. They had lunch. They had a lunch for the newer members, and the members could come and eat and talk and meet providers. And oh, by the way, if we managed to at the same time do one of our multidisciplinary evaluations, that's great. Doesn't always happen, but for some people it does. So it's just finding ways to find our way into people's lives that make sense for them.
John Lloyd, thank you. I'm aware time is against us. We've only got a couple of minutes left. How has this gone so quickly? I feel like we want to talk about it all week, but I imagine you've probably got other things to be doing. We're going to close in just 1 second by, we're going to go round. I'll just give my panelists in the room and in Boston due time to think. But it'd be great just to share one particular insight from our conversation which might encapsulate what we've been talking about, or one thing particularly you'd want to pass on to those who weren't able to join today. I will go first, then Annette, and then let's go John, and then Laura, you'll get the last word. So just one particular insight. And I think I could talk about so much, John Lloyd. Thank you so much. It's been a fascinating hour. One thing I'd particularly just pick up on now is how you talk about members. I think that's so interesting that you don't talk about your patients. And there is something about your model which seems so equal, that you work with your members on a level, and just that language I think just reflects your approach so beautifully. Annette.
I think there's so many favourite quotes from this talk, but my favourite one was when you said, "And then we'll tackle the health issues." because there were so many points beforehand that you had to get into place to do with housing, diet, and then just making sure that the cat was okay, and things like that was so much more important than actually getting the medical part sorted. And once those parts were put into place, I'm sure everything just fell in order much easily. So I will definitely be taking that with me. Thank you.
Annette, thank you very much. John, a single insight.
I think this healthcare and patients' lives and how we treat them as a journey, and you need to be on the road with them. And I think that needs to happen. And I'll just quickly share, I was talking to Bob Master, our founder, yesterday, who still practices on our hospital team. And he had 4 more ideas about how he could be a positive impact in people's lives. And I realized he lives this journey. And I think that's so important to understand that this isn't just one moment in time. This is a long relationship.
I think there's something that I think about almost daily at CCA, but is a good rule for all of us in our lives in any setting, but to really approach situations with curiosity instead of judgment, and to use that curiosity, which is what Bob does, which is what John does, to help us grow and to help us change. So we thank you guys so much for inviting us. And it's exciting to know that everywhere in the world there are seminars, there are things like this going on, because there are really good people with neat ideas wanting to make change.
Right, what a lovely point to end on. John, thank you so much. Just to check, John, is it okay if we share your slides?
Oh, sure.
Yeah.
Lovely, thank you very much. We will do that. Thank you for all who've joined live. We'll email those to you. If you're joining later, just email us hello@kaleidoscope.healthcare, and we can ping those on to you straight away. To say, this is the last webinar in the series. We've got a face-to-face event, a lunch on Friday. Again, email us if you'd like details of that. John and Laura, you're very welcome to come over to London for lunch on Friday if you're free.
We're there.
I imagine you've got other things on.
We'd love to. London is closer to Boston than California,
yes, it is.
So
Thank you for the opportunity.
happy holidays, everyone.
Lovely, thank you. And we hope to see you on a future webinar. Thank you, and have a good rest of your day.
Take care. Thank you.
Thank you.
Take care.
Thanks.